Hi, my name is Andy Roche. I'm a consultant foot and ankle orthopaedic surgeon here at the Fortis Clinic. I also work in Chelsea and Westminster Hospital. I have a special interest in looking after sports injuries in particular in athletes.
So we're going to talk about the reasons for an injection, why I feel an injection can be useful and what patients I will use it in. Possibly we'll talk a little bit very briefly about the substances that I use. Kathy covered this quite nicely with different types of formulas of things. Hopefully what we're going to talk about is some evidence-based, but also my experience-based as well. And we'll discuss a few contentious or controversial injections. So you may think that some of these injections aren't, but I think when you look at the evidence, they really are. And we're going to look at the Achilles tendon and also the plantar fascia. You know, we can talk afterwards about injections for ankle arthritis or osteochondral lesions or ankle impingement, but a lot of those I feel are fairly, clear cut. We know that patients who have got anterior ankle impingement from an inflammatory cause do well from a steroid injection, whereas sometimes these ones are less clear. So why do I inject the foot and ankle? Well, quite clearly I want to help the patients. I want to give them a therapeutic effect. Now that can be in the short term where you might have a patient who might be awaiting a surgical procedure. So commonly, a gentleman who's got a severe ankle arthritis, who might be listed for 3 or 4 months down the line, he might ask for an ankle injection because he's had them before and he knows it's going to benefit him, but he just doesn't want to have them on a recurrent basis. Patients who are wanting to do something, for a short-term gain. So I had a lady recently had a Morton's neuroma. She didn't want to have surgery, but she wanted to be able to walk up the aisle in her shoes, so she had an injection. Or patients who are playing professional sport or even amateur sport, they want to get through a season where they know they can play, probably get through till the end of the season, and then at the break they may want to have something surgical done about their condition. Obviously long-term gains, quite clearly we want to maintain the pain control long-term. Again, the one that springs to mind is the elderly patient with ankle arthritis or tib post dysfunction and subtalar joint pain. You might want to give them serial injections, sometimes until they're no longer needing serial injections for whatever reason that might be. Or if you've done something that hasn't worked and you're looking for an alternative treatment, so sometimes steroid injections and others can help. And quite clearly we're trying to cure these patients. So why do you inject the foot and ankle? Some of these patients just want injections. There's a number of patients who will come into the clinic and I'll say, "Hello, my name's Mr. Roche. Why are you here? What have you come to see me for?" "Oh, I want you to give me a PRP injection." First thing they say before I know anything about them, because they've been told that that's what we will do. So there are patients who, you start off your consultation on the wrong foot because they're expecting the injection. You can give them injections for diagnostic purposes. I think Jason touched on this with his facet joints. You're looking for the cause of the pain and the root of the pain. Patients may have conflicting symptoms, and in foot and ankle, it's very complicated, very complicated. There's a lot of things there beside each other. Things like the peroneal tendons and the posterior ankle. You've all seen these patients who have got posterior lateral ankle pain. You're not sure if it's the peroneal tendons or it might be the ankle impingement. It can happen at other parts of the foot and ankle. So every now and then you'll say, well, let me send you for an injection of the peroneal tendon sheath and see if it gets rid of the pain. Because even on an MRI, it's difficult to tell. The other cases where patients have what I call multiple pain generators. So you have patients with degenerate change in more than 1 or 2 joints. And you're really not sure which one is causing the problem. When you look at the anatomy of the hind foot, show part joint and the subtalar joint are really close together, and it can be really difficult to tell, especially if there's a deformity. So sometimes you might want to inject one of the joints purely to see if it helps. If it doesn't help, then you can inject another one to see if that helps. And you can keep going until you find the answer, because what I said to these patients is it's a damn sight safer for me to inject your ankle than it is to do an ankle fusion when it's not going to work. So I do think there's a real place for the diagnostic injection. So I suppose when you think about injections, we're all talking about steroids, really, aren't we? That's probably the theoretical gold standard. But so there's just been a good study done in the orthopedic foot and ankle literature a few years ago, where they just surveyed a number of orthopedic surgeons as to what they're going to be happy injecting steroids into. And quite clearly, very few of them, as you would be glad to say, don't go near the Achilles tendon, but they may inject the retrocalcaneal bursa. And as you go further down, they're much more likely to inject an arthritic ankle or an arthritic big toe or even a Morton's neuroma, because we know that has probably got significant therapeutic benefit. So there's a number of areas that we can inject, and unfortunately we can't talk about all of these today. So what do I use? Well, this is based on research that's looked at the chondrotoxicity, or how basically damaging these things are to cartilage. So for intra-articular injections, and I really roll this out to soft tissue as well, you're looking at a lower concentration of marcaine, which is less chondrotoxic than the standard 0.5%, and mix it with equal volumes of depomedrone, which has essentially been shown to have a higher solubility than Kenalog, which is the other one that a lot of people will use. Kenalog is useful in larger joints because apparently it's got a lower solubility, but in a larger joint that doesn't matter quite as much. And this becomes a safe concentration, and this is what my radiology colleagues would gladly inject if I was to send a patient for an injection. So when we're looking at steroids, obviously patients are, should be worried about complications. Okay, it's the ones that come in and say, "I want the injection no matter what." They're the ones I worry about. It's the patients who ask you about the complications. So we need to tell them what they are. There's obviously a long list: avascular necrosis, liver disease. There's a whole list of things. But the ones that I see are certainly a steroid flare. And you may have all seen this after somebody's had an injection. Thankfully, it doesn't happen in everybody because it's pretty painful. And it looks like an infection. It can go red, it can go hot, it can go swollen and tender, and they can't walk. But thankfully, it usually settles down quite quickly. Other ones are local tissue atrophy and skin depigmentation. I have seen this, and especially in areas around the dorsum of the foot or the anterolateral ankle where there's really no fatty tissue. There's not a huge envelope of tissue to basically dissipate that steroid. So they can have a local problem. Infection. So this is a lady who had an injection done, I'm glad to say somewhere else, but this could happen to anybody. And it was for an intrametatarsal bursitis. So very, very benign, innocuous injection. 4 weeks later, she looked like this. And you would assume there was nothing else in the history. She had a cortisone injection, and that's how it ended up. The risk of this, when I speak to Jerry Healy and Justin Lee and co, who've done hundreds, if not thousands, of injections, they really, probably it's way less than 1%, way less than 1%. But you need to tell these patients. So for 6 months of her life, she was struggling to get this to heal because the blood supply to that area is not great and the skin's quite thin. So you've got to be very careful when you're doing injections in areas where there's not a huge amount of skin coverage. Would I still do that injection? Of course I would. You just need to warn the patient. So the other thing we sometimes see, and I'd be interested, I don't know if Jason sees this when they do reconstructions around the neck, we see a lot of steroid deposition. And this is clearly this is an Achilles tendon who's had an operation, and it's clearly a patient who's had multiple injections of steroid around it, and it doesn't dissolve very well. It stays there, and it can cause hard lumps on the tendon, and it probably doesn't affect the tendon itself a lot, but what it does do is it means that I have to cut all these areas away, which leaves you with more damage to the tendon, probably more than what the patient needed. So we'll talk a little bit about some contentious issues: plantar fasciopathy and Achilles tendon disorders. So plantar fascia injections. I have to say I'm fairly conservative with plantar fascia and injections. I don't know, some of you may do a lot of injections, but I tend to use it whenever other therapies have failed or are not progressing as quickly as we would like. And what I mean by that is physiotherapy, shockwave therapy, gel pads, etc. Sometimes you can do it in the acute setting where the patient has a severe, sudden onset of plantar fasciitis. And really the theory behind that is you're catching it in the inflammatory phase, where they have a lot going on down there. There's a lot of swelling in the heel pad. So this is a patient who had one of probably the most severe plantar fasciitis I've ever seen. And I was convinced I was going to inject it when I saw him. And he came back a week after having had his MRI, and the MRI looked like that. And he told me his pain was better. But on the presentation, he couldn't walk. I had to give him crutches to get out of the clinic. So I think in the acute setting, there is an indication for that. What do we do? What do we inject? Steroids, PRP, dextrose, or dry needling. There are loads of other things that are in the literature, alcohol, all sorts of things. But these are probably the ones that we deal with most. So let's start off with steroid injections. There's a lot of studies out there, and as Kathy has already said, the methodology and the quality of the literature is very mixed. So you've got to be really careful when you're really drawing your own conclusions. And this is a paper that was a pretty good paper, randomized controlled trial in the orthopedic literature, that essentially looked at joint mobilization techniques and stretches versus steroid. And the reason I personally like this paper is because what it really drilled home was the concept of joint mobilization for plantar fasciitis, and not just sticking your foot up against the wall and stretching your heel out, which is what I'm sorry to say it, I'm going to our annual conference in 3 days. That's what everybody thinks works. You just put your foot up against the wall and you stretch it out. But this paper really drilled home the concept of joint mobilization, which I think works, or certainly helps. But the interesting thing, like Kathy said, the steroids really didn't give you a much greater benefit after 12 months. So for the first 6 to 12 months, it probably helps, but after 12 months, not a huge amount of benefit. And this is reflected in the vast majority of the literature for steroids and plantar fasciitis. Good short-term relief with local anesthetic, but not a sustained relief with the steroids. We see the complications of the fat pad atrophy, 1.5%. I think that's real. I've seen it before. I think if you have seen it yourselves, it's quite debilitating. Patients don't like it. Nerve injuries, plantar fascia rupture, infection, like the slides before, way less than 1% in my experience. Not seen a huge amount. So the holy grail of everything is PRP. Do we do PRP injections for this? Well, when you look at the literature is definitely mixed. There's papers like this that really show significant benefit of PRP over cortisone. So I think if you've got an injection like cortisone, which you don't like to do, and then you have a study that says PRP is probably better than the one that you don't like to do, then you should be more likely to use PRP. It makes sense to me. PRP is very hard to, it's easy to get. You essentially take some blood from the patient, but the machines, etc., not everybody has access to them. But what PRP has done that I think is different from cortisone is it gives the patient a more sustained relief. So this is a paper that was done 3 or 4 years ago. It's repeated by Tim Clough, who's a friend of mine up in Manchester, who basically is just a good guy. You think if he's going to do some research, he's well respected, he's going to do it well. And he did do it well, but he came up with a very sort of commonsensical conclusion where he said in chronic cases, PRP produces an efficacy rate approaching 2 out of every 3. So that's not sort of being very optimistic and over-egging PRP. It's just a very honest appraisal and opinion of PRP. So for that reason, it might well be worth trying PRP over cortisone. Dry needling, I don't know if you do dry needling or if you don't, but I've seen it done. I don't personally do it, but I've seen it done before. It can be painful for the patient, especially if you take them back 3 or 4 times. And there has been some studies that looked at sham versus the real thing. No other injected material, and they showed a very short-term benefit with dry needling at only 12 weeks, but I couldn't find any long-term studies to support the use of dry needling. What about prolotherapy, dextrose, polydocanol, whatever you want to use, but high concentration dextrose is used as an irritant and to really kick off a healing response. The problem with prolotherapy is you tend to have to repeat it like dry needling if you're going to do it that way every 3 or 4 weeks. And there's a lot of studies that will say there's a high dropout rate because the patient has it for 3 times and they wouldn't come back for the 4th because it's too painful. So you've got to think about that when you're offering this type of treatment. Does it really work? I don't really think so. I think the literature doesn't really support its use, but again, the quality of the literature isn't great. So when you think about injections, and Jason uses image guidance with X-ray for his injections, should we be using ultrasound? Well, when they did one study looking at the ultrasound's guidance, they found that the complication rate at 12 weeks was exactly the same whether they used ultrasound or no ultrasound, as in they didn't have any complications. And it was always my thinking you should use image if you have it. I think if not anything, it helps the patient, it reassures the patient because the radiologist, if they're good, will often show them the pathology. The patient then has an appreciation of what's happening, and they have an appreciation of what they have to battle with to get this thing better. So I find, I personally send most of mine for ultrasound because we have it freely accessible in the clinic. Okay, let's move on to the Achilles tendon. Again, the Achilles tendon, you have a number of substances that you might want to inject, PRP or blood. And the reason that says PRP stroke blood, there's a huge amount of trials out there that have looked at PRP, and it's always called platelet-rich plasma. But then other studies call it property-rich plasma, because nobody knows exactly what concentrations are effective or which of those 4-letter growth factors that nobody ever understands are in the thing that's going to work. So the PRP literature is mixed. So with the Achilles tendon, I'm glad that Kathy touched on this because you've all seen many Achilles tendon problems. You have to decide on what intervention you're going to use based on clinical findings. And that sounds very obvious. Because if you say to somebody you're going to do an injection for an Achilles tendon problem, everybody's going to automatically say, oh, they're going to have a high volume injection, because that's the only injection you can have for an Achilles tendon problem. But what you have to do is you have to work out if it's an insertional disease or if it's a non-insertional disease. Because quite clearly, if it's a non-insertional disease, you have the paratenon, you have the Kager's fat pad. If it's an insertional disease, you have the insertion onto the calcaneum and the retrocalcaneal bursa. So you're treating different things, and there's different approaches you need to take. If you read an MRI report, they often say there's a split in the tendon. Now, we often get people who say they've torn their Achilles tendon, and quite clearly that's a different thing. A split could be a degenerate longitudinal defect in the tendon that functionally may not be causing anything symptomatic, but on the scan has been picked up as a tear or a split. So that can influence your treatment. Do they have a generalized swollen tendinopathy, the classic, diffuse Achilles tendinopathy? Because again, that's something totally different from a simple split or a tear. Is it a very superficial pain? Is it an acute pain? Is it a paratendinitis? I'm not going to bang on about the difference between an itis and a non-inflammatory condition. That's all sort of done and dusted. But sometimes you can see people with an acute, inflammatory disorder of the paratenon, and it can often be very severe. Or is it on the medial side? You hear people talk about plantaris pain. Do you have a very isolated medial pain in the Achilles that isn't a circumferential problem? It hasn't got swelling all around the tendon. So when you look at insertional disease, you clearly have different presentations. The only one that I would advocate treatment with an injection acutely for is the one on the bottom right, which I think in this room design probably doesn't project very well, but essentially what you're looking at is a retrocalcaneal bursitis, an isolated retrocalcaneal bursitis. I think that's something that can be targeted by a steroid injection, always under ultrasound in my opinion. The other ones, the guy on the top right, he's got that massive spur on the back of his heel. You can inject that till the cows come home, but nothing's going to make that better until that piece of bone goes away. So that will need surgery. The one on the left has got a mixture of bony prominence, but also, if you look closely, some little bodies in the tendon insertion. So that's probably a degenerate tendon where you don't really want to be going anywhere near with a needle, and certainly not anywhere near with a needle filled with corticosteroid. So the one that we think about mostly for injection therapy is probably mid-portion Achilles tendinopathy. And with PRP, again, we know that the animal models have shown quite nicely that you can reduce the neovascularization, improve the disorder, you can improve and normalize the tendon structure by upregulating collagen-1 production. You can throw out loads of pro-inflammatory mediators. So there is a lot of work there that says PRP does this in animals. The problem is, in the clinical evidence in human studies, even though you've got some very good randomized controlled trials that actually are some of the better ones, and I think what Kathy said is very important, some of the better trials give you better results that probably are negative. And that's really important, I think, in PRP application for Achilles tendinopathy, for mid-portion tendinopathy, because quite frankly, none of the literature has really strongly advocated the use of PRP for your classic mid-portion Achilles tendinopathy. We know, however, in Achilles ruptures, which you may not think that PRP has an application for Achilles ruptures, but there has been some good studies done in animal models which you know that if you inject PRP onto the repair intraoperatively, you can accelerate the tendon regenerate and it can really improve the strength of that tendon. And there has actually been a recent study published in The Lancet this year that did exactly this. That they did an Achilles tendon repair. They biopsied the tissue. It was only at 6 weeks, but what they did show was that they had a better type 1 collagen deposition and improved healing response. It does add some fuel to the fire that PRP probably does have a role to play in the acute, probably inflammatory Achilles rupture, okay? So when you look at the sort of clinical trials for that, then you have some trials that were done in 2007 that did exactly that. They used a platelet-rich fibrin matrix. So it's not an injection of PRP, it's an injection of PRP onto this matrix that was made up of VEGF and FGF and all these other ones. And they found that these patients got back to sports, running and training a lot quicker, which is probably what we're interested in, because that's what they want to know. They want to know, am I going to get back quicker if I have this type of operation or that? And they found that using this particular PRP matrix, they got back to training and to running significantly quicker than those that didn't have it. The problem is, even one of the conclusions from this trial, there was no consensus on the dose or the concentration of the PRP vehicle. 4 years later, you look at this trial, another very good randomized control trial that looked at what they called autologous platelets. So even people are calling them different names. And they didn't see any significant difference at 12 months. So really, there's two camps of PRP with Achilles ruptures. Do we use it? Yes, we do. We use it personally because I believe it does improve the strength and it does accelerate the healing. And rightly or wrongly, I don't think it does any harm. We have a lot of patients that want us to throw the kitchen sink at them. And I do believe that if there is some evidence out there to suggest it works, and the patient knows they've had everything done possible, especially the higher level athletes, I think it's a good thing to do. There is evidence there, so it's not like we're just doing it off the bat. Steroids, very quickly, I don't think anybody really uses steroids, certainly in this country, very often for the treatment of Achilles tendinopathy. The ruptures are definitely anecdotal, but they're there. There is some studies, and even this year there was a study published in our big journal for advocacy of the use of steroids in Achilles tendinopathy. The problem with most of these studies is they're throwing everything at it with steroids. There's local anesthetic, there's aprotonin, there's saline, and really it's very hard to tell what is the effect of each thing individually. We know that intra-tendinous injection is not really recommended. Where I do find it useful and I do use it is in that sort of very unusual paratendinitis or in that retrocalcaneal bursitis, which is a judgment call. But if you have a patient who you think might have this problem, the important thing is, have they got tendinopathic change on the scan? If they don't have any degenerate change on the scan, you're probably more likely to go ahead and use steroid than if they did have a tendinopathic change. Prolotherapy, again, I find it useful for the very small localized areas of degeneration. The splits in the tendon that we mentioned earlier on, sometimes the radiologist can target that split with an ultrasound guided probe and inject some prolotherapy, basically irritant, high concentration dextrose around that. So we do have a protocol in Fortius where the guys will use usually less than 5 mils of fairly highly concentrated dextrose. High volume injection, I suppose that's the one that all the patients have heard about, all the patients know about it. And what we're talking about is essentially injecting into Kager's fat pad, which is just in front of the white arrows in front of the tendon. And you're looking to devascularize the tendon by basically stripping off that neovascularization. You're looking to denervate it because there's a lot of pain receptors that go in from the front of the tendon, and you're looking to take that away. And that doesn't help anybody but the physios, in my opinion. It helps you help the patient afterwards, okay? The other thing you're looking to do is essentially just get rid of the adhesions to allow that tendon to glide a bit better. So when you're talking about Achilles tendinopathy in the mid portion, you can have that sort of long tube of swollen, horrible tendon, or I'm starting to see more, and probably because it's just being recognized more because of the literature behind this, a very sort of isolated medial effect where you think the plantaris tendon might well be causing a problem. You've all heard about it. So the plantaris tendon runs medially along the side of the tendon, and when you look at it intraoperatively, it can be stuck down on the side of the Achilles, and then theoretically you release it or you cut it away. So if you're trying to do that with an injection, you might think, well, why don't you, it's going to be a lot easier. You're essentially doing the same thing as an operation. Sometimes now we tend to actually remove the tendon rather than just strip it off. So the plantaris effect can be down to a lot of things. It can be down to the fact that we know the properties of the tendons are different. The plantaris is a much stiffer tendon. So if you have a much stiffer tendon alongside a much more elastic tendon, you're going to get two different complete mechanisms and lines of action. We also know that from some of the studies that have been done that you can have anatomical variations where the plantaris tendon can actually be stuck onto the Achilles tendon. Now the problem with these cadaveric studies is they said, oh, this was a new finding, that in 10% of patients the plantaris tendon is stuck onto the Achilles. The problem is they didn't have any of the medical history of those patients, and that may well just have been tendinopathy. We don't know. But it could be from an anatomical variant. MRI scans can definitely show localized changes, and please don't ask me to explain this too much, but we have started to use hyaluronic acid to essentially act as a lubricant to strip the plantaris off the Achilles tendon in a very localized medial sided disease in the Achilles tendon. And there's nothing published about this at all, but it's something that seems to make sense to us, and we are using it, not in everybody. It probably has a similar effect to saline, but with more of the biological properties of the sort of the ostenal tendon properties that you can find. So it's a bit early to tell if this is going to work long term, but it's something that we're going to look into in more detail. So in summary, I think the injections in plantar fasciitis are often short-lived, but what they do is they facilitate an environment to help the physios to allow that patient to recover. I think PRP may well be worth revisiting. I did a sort of straw poll of my colleagues in Fortius about who would be inclined to use it, and I think 2 out of 5 said they would use it. The other 3 said they were happy just with where they were. So I'm not sure what way we're going to take this, but I think there is evidence out there. So as a result, there's no real gold standard injection for plantar fasciopathy. I think in Achilles tendons, I think it's important to sort of ascertain exactly what the pathology is and really avoid you know, that high volume, because patients, they come in and they say they want a high volume injection because they know about it. And I think you have to avoid that blanket term because the presentations vary. I think the PRP use in Achilles is probably not useful. I think you can safely tell your patients that it's highly unlikely to work unless they have an acute rupture, in which case then it can be administered intraoperatively. Thank you very much.